Today I'll be discussing Chapter 7 from your book, which is all about diuretics. These are medications that are given to prevent the kidneys from reabsorbing sodium and water. We'll go over some terms and abbreviations. We'll also state the general purpose of diuretics. We're going to talk about the renal process of blood filtration and excretion, talk about anatomical structures of the nephron, and explain the potential impact of long-term diuretic therapy on the patient about to undergo a surgical procedure. We're also going to talk about intraoperative uses of diuretics and how those differ from long-term use, and then we will talk about some different types and categories of diuretic agents. So the first thing we're going to talk about is the preoperative phase. So when we're talking about preoperative, this is the time before the surgical procedure. Keep in mind that diuretics are given to manage some chronic medical conditions like hypertension and congestive heart failure. So some of these patients that are on diuretics long term, they may experience hypokalemia or serious potassium depletion. This is what that term means. Hypokalemia means too little potassium. This can be a reason to cancel surgery because potassium levels that are too low or too high can cause some cardiac dysrhythmias under anesthesia. So this is why we're concerned about potassium levels of patients before they come to surgery. So diuretics, these are medications administered to reduce body fluids by preventing the reabsorption of sodium and water by the kidneys. So as a result of using these, the patient's going to excrete large amounts of dilute urine, known as diuresis. This will also cause them to excrete sodium, potassium, and calcium. So these different substances will be lost with the water as well. Subcategories used in the management of chronic conditions. So when we're talking about this, it can be used for hypertension. It can also be used for congestive heart failure and glaucoma. So when we're using this for hypertension or high blood pressure, it's going to help eliminate fluids, which decreases blood volume. So when you have less pressure on the vessels from lower blood volume, the heart doesn't have to pump as fast or forcefully, so it's going to decrease the blood pressure. In congestive heart failure or CHF, the heart muscle is too weak to pump effectively, so it's going to help with that. And then glaucoma is the increased intraocular pressure in the eye, so this can help decrease that pressure. Electrolytes are minerals that are made up of electrically charged particles, and they're held together by ionic bonds. We have some major electrolytes in our body, and these are going to include sodium, potassium, calcium, chloride, magnesium, and phosphorus. All of the electrolytes found inside and outside of our cells are acquired through food and water. Most diuretics are going to cause the excretion of fluid in the form of dilute urine, like I already mentioned. So again, this is going to help to lower blood pressure by increasing the elimination of fluids from the body, which will in turn decrease the blood volume. So then with that less blood volume circulating, there's less pressure on the blood vessels and the heart doesn't have to work as forcefully or fast. And if you read in your textbook also, they're going to mention a water balloon example that might help you to relate that a little bit better. So we're going to touch now on the renal process of excretion. The primary function of the urinary or renal system is to maintain homeostasis by filtering blood and removing excess water and dissolved substances or solutes. Some of these solutes we're talking about are sodium and potassium. So filtration, when we're talking about this is the process of forcing fluids and solutes through a membrane by pressure. An example of this is brewing coffee, and when you have that coffee filter and you're pushing that fluid through. The nephron is a microscopic filtering unit. So these just help, again, the kidneys to filter water and waste solutes. They're a microscopic filtering unit, so the only way you can see them would be through a microscope, and there are millions of these present in the kidneys themselves. So we're going to talk a little bit about the physiology of the kidney. So on each of the next couple of slides, you can see the picture, and as I mentioned the structures, you can kind of relate to where they are. So the blood, and this is going to be a nephron here, what we're talking about. So the blood is going to enter the nephron through the afferent arteriole and into something called Bowman's capsule. So this Bowman's capsule is actually where the filtration is going to occur. So this is where those fluids and solutes are forced through a membrane. After filtration, the blood is going to be filtered, like we said, and return to circulation through the efferent arteriole. And then the rest of the fluid that's left undergoes tubular reabsorption. Tubular reabsorption is the process by which specific amounts of water and other needed substances are taken back up by the body. So this is going to occur in the proximal convoluted tubule and the ascending and descending limbs of the nephron's loop, which are also called the loop of Henle. After tubular reabsorption, the filtrate is going to receive materials like potassium, creatinine, and hydrogen ions from the blood surrounding the tubule. And then it's time for that tubular secretion in the distal convoluted tubule. So what this tubular secretion is going to do is eliminate waste, and it will also help to control blood pH. So then more water is going to be reabsorbed when the filtrate proceeds to the collecting ducts. From these collecting ducts, it's going to empty into the renal pelvis and then to the ureter and the bladder. So when the filtrate is excreted, this is called urine. So don't get too caught up on all of the anatomy and process. It's more just a review so you guys can think about how these drugs are working within the body. So we're going to talk a little bit, just hit the high points of some of the anatomic structures of the nephron. So the afferent arteriole is what brings the blood into the glomerulus, and then this glomerulus and Bowman's capsule is where filtration actually occurs. And then the efferent arteriole takes the filtered blood back to the circulatory system. The structures, the proximal convoluted tubule and the loop of nephron, this is where tubular reabsorption happens. So water and solutes are removed from the tubular fluid. This is before urine, and it's going to return to the circulating blood. The distal convoluted tubule is where tubular secretion eliminates waste products, and then the collecting ducts hold the filtrate until they are emptied into the renal pelvis. So we can see diuretics are going to be used for treatment of many diseases. We just want to think a little bit about the preoperative and the intraoperative implications of diuretic therapy. So keep in mind that potassium is a very important electrolyte, and it can be seriously depleted in patients taking certain diuretics because it's being flushed out with those large amounts of urine. A couple terms you need to be aware of: hypokalemia. This is when the level of potassium in the blood is low, and hyperkalemia is when the level of potassium is high. When you think about hypo and hyper, these are terms you're going to hear a lot, so just think back to your med term days. Hypo means below, and hyper is above. So that's what it's referring to. And if you keep those straight, it'll help you a lot. An arrhythmia is the absence of a normal heart rhythm. So this can be caused by either hypo or hyperkalemia. And then also hypokalemia, this can cause some muscle weakness, which makes muscles more sensitive to muscle relaxants used for general anesthesia. So that's just another reason why we want these levels to be normal when a patient's coming to surgery, because we don't want general anesthesia to adversely affect them. If somebody has significant hypokalemia before surgery, they may actually need to get an IV potassium infusion if it's not an emergency surgery. Um, you don't want to give this too rapidly, though. It can take some time because it will mess with heart rhythms if it's given too quickly. So if they can and it's not an emergent procedure, they may just delay and reschedule for another day. So like I mentioned on that last slide, you don't want to give the potassium over too short of a time period. You want to space it out. And then also just keep in mind that long-term diuretic therapy, you're most frequently going to see this in elderly patients because maybe they have some systemic fluid management conditions. They're not able to regulate themselves. So like we mentioned, congestive heart failure, hypertension, glaucoma, all of those things might cause them to be on long-term diuretic therapy. So we kind of mentioned this already, the impact of long-term diuretic therapy. Since they do excrete large amounts of dilute urine, they're also going to excrete potassium too. So when these levels are depleted, we kind of mentioned that it's called hypokalemia, and these patients are going to be at an anesthesia risk for cardiac dysrhythmias. If you guys are wanting to know too, normal potassium level is going to be anywhere from 3.5 to 5.0. Again, patients that you might see on long-term diuretic therapy, they might have congestive heart failure, hypertension, glaucoma, all of those type of things. Sometimes you'll see patients that have come in with a hip fracture or are having a vascular procedure done. And they may also be treated with diuretics. All these vascular procedures, the reason they use it on there is if they're having an aortic procedure done, it's going to help the kidneys functioning. Also, those elderly geriatric patients. So we're going to talk a little bit about a couple scenarios here and what we might do due to their potassium levels. So first up, scenario one. We have a patient that fell on Friday and fractured their hip. So they are scheduled for surgery on Saturday morning. Their potassium level is 2.9. So in this case, we're going to get everything ready, but we're not going to open the sterile field. So why is that? The potassium levels are not in the normal range. We mentioned that 3.5 to 5.0 is the normal level, and you can see that they're below that. So in this example, we're going to just hold off for a little bit. Anything, as we mentioned, even a little deviation from normal potassium levels can cause a problem during surgery. So the anesthesia provider is going to have to clear this patient even before an urgent procedure can go on because they may not be comfortable with doing surgery on somebody that has a low potassium. They may want that addressed before they move on. So diuretics are rarely administered from the back table in surgery, but it's important for you guys to understand how the use of intraoperative diuretics affects the surgical patient. So if we're using them during surgery, it's going to be short-term therapy. So maybe a condition is going to require a very quick but temporary reduction in fluid volume. With these patients, it's going to be really important that they have a Foley catheter in place because they will have a large excretion of urine. So it's important that that be put in place so then they can measure through the drainage bag how much urine they're actually outputting. So here we have another scenario. So this is an 82-year-old man with congestive heart failure. So he has been on long-term use of diuretics. So he is an add-on case for 7 p.m. for a femoral embolectomy. This means that he has in his femoral artery a piece of like a clot. So his potassium is 2.7. So we see that that is well below what we want it to be. In this case, though, we are going to open the items and proceed, and I will tell you why. This constitutes an emergent procedure. So even though he has that low potassium level, we need to do the surgery, because if we don't do it, there's a good chance that he might lose that limb because there's no blood flow down all the way to his foot. So the anesthesiologist may choose to either do a local or regional anesthesia to help offset the risk. By not giving them general anesthesia, it's kind of helping to prevent some of those arrhythmias that might occur. They still may give potassium through an IV, but it's going to have close cardiac monitoring, just because the possibility of an arrhythmia from the fluctuation of those potassium levels. Because as we mentioned before, you want to do it over a longer time period. So we talked diuretics are used over the long term to manage chronic fluid conditions. Short term, we can use these for reducing intraocular pressure. Also, we can use these to reduce intracranial pressure, and we can use them to protect kidney function. And after surgery, they're also going to help to control swelling. I just want to mention, when it's talking about intracranial pressure, so maybe they have had a traumatic brain injury and we're bringing them to surgery for a craniotomy. By giving them diuretic, it's going to help decrease that swelling. So hopefully we can also put the bone flap back on after we've done surgery on the brain, and it's just going to help to decrease that swelling and hopefully minimize complications. Okay, and here is the last slide. I'm sure the one you guys have all been waiting for. So these are the categories of diuretic agents. I'm going to briefly talk about each one. You're not going to have a lot of information on your slide. You'll just kind of have to listen to what I have to say. And then any important ones I will talk about in lecture when we meet on our Zoom call too. So loop diuretics. These are highly potent and remove fluid by inhibiting the reabsorption of 20% to 30% of the sodium load. One drug you're going to be familiar with this is Lasix. This is a broad action. It can also be used to treat CHF, and it's very helpful in reducing intracranial pressure. Thiazide diuretics. These are low potency and used to treat hypertension and mild chronic edema or swelling. They inhibit reabsorption of 5 to 10% of sodium load, and this is usually seen in a medical setting, so it's not something that's going to be used in surgery very often. Potassium-sparing diuretics are low potency and used to treat edema and hypertension. They inhibit only about 1 to 3% of the sodium load, and they're usually also seen in a medical setting. A lot of times these will specifically be used in combination with loop or thiazide diuretics to help minimize potassium loss. Carbonic anhydrase inhibitors, these are low potency and they are used to treat the glaucoma, which we'll talk about more in chapter 10. These specifically decrease the production of the aqueous humor. And then lastly, osmotic diuretics are highly potent and these work through osmosis. An example is going to be osmotrol, or mannitol is the generic name. These are given through an IV. They can help to prevent acute renal failure after cardiac surgery. They treat increased intracranial pressure and cerebral edema or swelling. And then they can also reduce intraocular pressure in open globe procedures of the eye, like retinal detachments. These will specifically draw fluid out of tissues and into the circulatory system. They do this pretty quickly. They'll also to help protect kidney function, and they can be used for malignant hyperthermia. We'll talk about this in one of our very last chapters as well. So I know that's a lot of information on that specific slide, but again, I'll hit the high points of that when we get together on our Zoom call this week. So be sure to write down any questions, and we will talk soon.